Good afternoon, everyone. Welcome to Ask the Experts.
Yeah, good afternoon. I'm Sue Weldon. So good to see everybody. And I'm here with my colleague, as you know, Erin Pellegrin, who leads these wonderful Ask the Experts. Erin, it's been a little bit. I don't feel like I've been on with you for a while.
I know, and I'm glad you're joining because I feel like this is a really great discussion to have your perspective on. But we know that this is a topic we haven't addressed before, but these kinds of questions come up all the time, and I think it prompts a lot of thought as our community connects with their own surgeons.
Absolutely. And I know that Dr. Light, we were so fortunate that he was with us in February and he focused on all these wonderful solutions for challenges that we face with breast reconstruction. Dr. Light, I've had my share, but always be able to guide it. Being guided is so key. And then you end up, walking through with somebody like yourself who professionally gets you there. So never easy,
It
but
is, and
I'm I'm
a lot of
glad.
times it's multi-stepped, and there are some women who are fortunate, and for a number of reasons, it can all be done in one step. And then there are others that have some issues along the way, or it's a more complicated situation, and it requires a little bit more work and a little bit more time. But having a little patience and a little faith that your team is going to get you there, I think is the most important thing to staying sane and collected through the process, which is not always easy. It's not always easy.
Yeah,
Yeah.
but so well said. I absolutely agree with you that patience was key for me and I
Mm,
got there. I got there. So it isn't always one size fits all, right? So that
Correct.
is,
absolutely.
thank you for that.
100%.
All right, Erin,
Yeah.
before we dive in, what do you think? A little housekeeping?
Absolutely. So today our focus is all about breast implant care and safety. So Dr. Light will be with us asking those common questions, as well as many of our questions that we got in from our community. Great questions have been submitted, so we'll get through as many as we can in the time that we have. I also want to make sure that we thank our sponsors. So our digital education events today are presented by West, Merck, and Daiichi Sankyo, with additional support from Gilead Sciences, Lilly, GSK, Pfizer, and Agendia. And I want to make sure we pop up this slide because they are, continuous supporters of our
Yeah.
education events, all of which you can view at UFH Connect, which is our ever-growing video library. So not only will you be able to come back and watch our Ask the Experts with Dr. Light today, but you'll also be able to see her speaker series from early February as well. So definitely be sure to check those out.
Yeah, thank you, Erin. We have the honor of working with these supporters and partners of ours day in and day out, and we can't do what we do without them. So I appreciate that time to put that up on the screen. They are a true partner in every sense of the word. I always say with our integrative care approach, we can't do it alone. We need that medical team, and we need that nonprofit team, and we need the pharma team all together so that we can have the best patient care.
Absolutely. But we don't stop with today with our education events, although we're rounding out March with a really great segment. We've got so much more coming next month. So some quick teasers for you. Hopefully you've been following along all month long for National Nutrition Month. Every Friday, Instagram Live at 10 a.m. Eastern, we've been doing Dear Dietitian. So each member of our team is just answering a couple of those questions that have come into our registered dietitians. Catherine will be joining us live tomorrow to go through a couple questions that have come in. So be sure if you're popping on social media tomorrow, feel free to join the Unite for Her Instagram page to watch Catherine go through some of those questions that we've had. And then we're kicking off April with our virtual hangout. So April 2nd, which is a Wednesday, 5 p.m. Eastern time, we will be joined by Sissy Silva from Cancer and Careers, and she'll be helping us through balancing work and cancer. So we all know that work after a cancer diagnosis can bring many unexpected challenges. So this segment will focus on the complexities of navigating work, both during and after treatment. So if this is something that you are sort of working through, definitely join us. And of course, again, you can pop onto uniteforher.org/UniteForHerConnect to view our future segments and all of our past educational episodes.
Yeah, it's an incredible community that we have built over the past 5 years now, Erin. And
Yeah.
the topics, we always do intakes to make sure that the topics are all relevant, all the information is relevant and up to date. And I just love doing that search, of the library, because there is a lot that we have done on several topics, one of them that we're talking about today. So thank you, Erin, for hosting all these for us. And we are looking forward to getting into Dr. Light's segment.
Absolutely. Let's do it.
I have to tell you, I've spent some time in your library as well, and I'm really starting to enjoy it quite a bit. All of the
Oh,
nutrition
good.
tips and all of the information that I've gotten out of it to share with my patients, it's really great. Um, Definitely referring a lot of people to your site because of just the wealth of information on a topic that a lot of people don't cover it. So thank you.
Oh, you are so welcome. All right. How about if we give Dr. Light a formal introduction? What do you think, Erin?
Absolutely. He deserves it.
All right, Dr. Light is a medical doctor in the fellowship trained board certified plastic surgeon with an expertise in microsurgical breast reconstruction. Dr. Light trained at the world-renowned Cleveland Clinic, University of Pennsylvania, and Fox Chase Cancer Center. He performs more than 300 primary and complex revision breast reconstructions each year and has a special interest in helping women who were never offered a reconstruction or are unsatisfied with their current reconstruction. So Dr. Light, we appreciate you. We thank you for coming back again. I'm glad you are looking at that library. There's so much information there to support your patients and give them that, experience and community and just whole patient approach to healing. So thank you for all you do.
Thank you.
Yeah.
Wonderful. Well, let's jump right into some of these questions. And I want to encourage anyone that's joining us live on Facebook, feel free to add your questions as we move through the conversation. Like I said, we'll get through as many as we can. So just jumping off, this is a question that we hear so often. Several of our community members have posed this question to us as well. Dr. Light, share a little bit about the difference between saline and silicone implants.
Sure. So both implants actually have a silicone shell. So the outside of the implant is the same. And the difference between current implants, which are basically fourth, fifth generation implants, and the original implants is the original implants were just, some of them were single shell layers, single shell layers. Some had a couple of shells. The modern implants are multi-shell layered, and so the resilience and the durability is definitely a lot better than the implants in, going back to the 1980s. The silicone implants are filled with a silicone gel, and the gel can differ a little bit in what's called cohesivity. So that's the degree that the gel sticks to itself. So the higher or the more cohesive the implant, the thicker the gel feels, the less likely it is to ripple. And so the sort of common term for them are gummy bear implants. And then there are implants that are a little bit softer. And so there are some patients that will have issues with rippling. We'll use a higher cohesive implant. And then for especially cosmetic patients where the breast tissue is there to hide the implant, they may want a little bit more of a softer implant that's less cohesive. So that's silicone implants. Saline implants, again, that's silicone shell, but now it's filled with saline, which is essentially salt water. So the advantage of we talked about the advantage of the silicone implant in that the more cohesive it is, the less it will ripple. Some patients also feel like the silicone implants, because they feel a little bit more denser, they feel a little bit more natural. And so that's another advantage. The disadvantage to a silicone implant is that you need to monitor it. What I mean by that is you need to do imaging to make sure that the implant hasn't ruptured, because it is possible for a silicone, the shell on a silicone implant to rupture, crack, break down, but the breast does not change shape. And so there's no clinical sign or external appearance that something is wrong. And so the FDA recommends that we do an MRI 5 years after a silicone implant goes in, and then every 2 years after that. The advantage of a saline implant is you don't have to do an MRI. So for women who don't like MRIs, may get a little bit claustrophobic, or just don't want that maintenance to it, they may choose a saline implant, knowing that, or hopefully they know that or are told that, a saline implant does tend to ripple more. And so with reconstruction, silicone implants are a little bit more popular because of the rippling. If you think about it, the difference between a breast reconstruction and a breast augmentation is that with a breast augmentation, the breast tissue is still there to hide the implant.
Right.
So using a saline implant or a less cohesive implant is okay because there's more tissue to hide the imperfections of the implant, like rippling. And actually, I'm gonna grab an implant here so everyone just gets a little bit of a better idea. That's
Yeah.
rippling in the implant. So even when it's sitting in the body, you can see this rippling. A saline
Wow.
implant will ripple more, which is the disadvantage. But again, you don't need to have the MRIs with the saline implant. If a saline implant ruptures, your body will simply reabsorb that extra fluid. You'll notice a change. Sometimes it's immediate. It's after a couple of days, a change in the shape of the breast, and that alerts the patient to, okay, something's wrong. Let me go back and see my doctor. I need to have my implants exchanged.
Okay. And both types of implants are safe. We got a few questions coming in just about the safety of both types from our community.
Yeah, so I think we placing implants are very popular. Are implants safe? I think that any device that you put in the body can have complications, and there are certainly complications specific to implants. So I think overall implants are safe, but that determination of safety, I think, is really up to the patient because you need to understand what the downsides are to having an implant, what the surveillance is, what the possible complications are. And then it's really the patient who's saying, okay, I can accept that. That's fine. We can move forward with the implant, or that doesn't sit well with me. I don't like this, or I don't like that. And this is not an option that I want to move forward with.
Got
So
it.
I
Understood.
do think it's a combination, it's a joint decision, the shared decision making between the physician and the patient.
Yeah, absolutely. That's a good call out.
Yeah, Erin, I think I'm going to jump a little bit because since we're talking about implants, can you just talk a little bit more about the textured implants and are they safe? Because that came up. I remember when that came up with our community a couple of years ago.
Right. So textured implants are associated with breast implant associated ALCL. And you will see this abbreviated BIA-ALCL. And it's essentially a lymphoma that is associated with the texturing on the implant. And I don't know that we know the exact mechanism for it. There was a hypothesis that the texturing on the implant basically causes a metaplasia. In other words, it takes normal white blood cells, lymphocytes, and causes them to change into a cancerous cell, a lymphoma. And it's that texturing, it's the chronic inflammation that happens from the texturing. That inflammation, maybe partly from the actual physical texturing, but we also know is that with textured implants, in all of the nooks and crannies of that texturing, it's sort of little pockets for bacteria to reside. And it may not be enough bacteria to cause a infection that we would see externally, redness, fluid, fevers, chills, but it can be enough bacteria that it causes this smoldering low level of inflammation, which can also lead to this metaplasia that I mentioned, and that's referred to as a biofilm. And so I think that when the concern or the link between textured implants and breast implant associated ALCL came on, there are many plastic surgeons who immediately backed away from textured implants. Now, as the incidence has grown for a few reasons, number one, people were aware of it. Multiple papers became published. The American Society of Plastic Surgeons had, focus groups that were, dedicated towards researching this and trying to identify it. So that definitely raised awareness. So it was on people's radar. And then there are also markers. So there are specific tests from the fluid that it sits around the implant that can diagnose breast implant associated ALCL. So once there was a test for it, now it's very easy to say, yes, definitively, this is what the issue is. And that patient can be identified, their history is reviewed, all their previous pathology, any other comorbidities, all looking for links to see, why is this happening? Who's it happening to? When does it happen? Does it happen within 6 months after surgery? Does it happen 6 years? And we know it can be delayed. And so in my practice, I haven't put a textured implant in almost 10 years, just because I'm just not comfortable putting that risk. And when I explain it to patients, they immediately say, no, that's not something that I'm interested in.
Yeah. What was
so?
What was the purpose of the texture, if I may ask, initially? What was the thought behind it?
So textured implants, there used to be a thought that the texturing would decrease the rate of capsular contracture, and that's not true. Then there were times when implants, the texturing basically helps to hold the implant in place. So there were surgeons at one time that every single case they did was with a textured implant. There were other surgeons who might use both, and maybe they would use a textured implant on a revision case where there was implant malposition. So they put a smooth implant in, it kept moving to the side or bottoming out, and they put the textured in to help the implant sort of stay in place and not move. Then shaped implants came out, teardrop shaped implants. And because the implant has a specific shape, it needs the texturing to help hold the implant in position. Because if a teardrop shaped implant turns upside down, the shape of the breast is not appropriate. All of the volume, the majority of the volume is at the top of the breast, not at the bottom, and it sort of looks like the breast is upside down. So those implants were all textured, and that was almost like a resurgence of textured implants, because when they came to the market, everyone wanted to see if these implants would make a difference for their patients. But I think as the popularity of the shaped implants fell off, and as the incidence of breast implant associated ALCL rose, I think the vast majority of surgeons now use smooth round, and many like myself only use smooth round implants.
Got it. So going back to, I was
Oh,
going to say, we got a
sorry.
question. No, we got a question in from Facebook, which kind of pertains to that first type and sort of this conversation about types of implants. Is it generally up to the plastic surgeon which type of implant is used and which holds up longer between saline and silicone?
I actually leave it up to the patient. So there may be plastic surgeons who have a strong preference. This is what they feel, works best for them. I always like my patients to be involved. The same discussion that we just had, discussing advantages and disadvantages, more rippling, less rippling, you need an MRI with silicone, no MRI with saline. That's the discussion that I start with. And if that's enough for them to be comfortable with a decision, that's where we move forward with. Sometimes we get down into a little bit more of the nitty gritty, but for most of the vast majority of my patients, they're picking the type of implant that they want.
Right.
Yeah, I know, Dr. Light, when that first came out about the textured implants, we had so many of our community members wanting to swap them out, and to do so, a lot of them have done. Is that still the recommendation, is to get them swapped out or to wait? Because it sounds like you do have a mechanism now to test that.
Yeah. So I think the official recommendation from the FDA and the societies is that you do not have to switch it out. You can just monitor. However, if you have a device in that, especially for, you know, if it was placed for cosmetic reasons and it's not essential, and if it was placed for reconstructive reasons and you have another option, I have a hard time looking my patients in the eye and telling them, let's just monitor this, when I know if it was in a family member, I would want it exchanged. Like, why even run that risk? We exchange implants because the patient doesn't like the size. We exchange implants
Mhm.
because of like reasons that are less concerning than you know, a potential risk for cancer. And so I don't have a problem with anyone, you know, requesting that their implants be changed because they're textured.
Yeah, and that's much less invasive, right? When you're swapping out your
Yes, yeah,
implants.
if it's
I
a
think as a breast
pure,
cancer survivor, like you're sort of thinking of that initial type of surgery and thinking you have to go through that all over again, right? But it is a more or less invasive
yeah,
approach.
yeah, I mean, it's an ambulatory surgery. If it's just purely exchanging the implants, I mean, it could be under an hour and, you know,
Wow.
with not a significant amount of recovery. So we're talking about a low, um, you know, not a lot involved, not a lot of recovery, not a lot of investment in time, that it's, you know, sometimes just for the peace of mind, it's worth it.
Yeah.
Yeah.
That's great. So speaking of timing,
Mhm.
we got another question, and I think, one thing that comes to mind are, do implants last forever? And some of those associated questions, like, or when do they need to be replaced? What's that timeline look like?
Right. So implants do not last forever. In fact, in 2019, the FDA put a black box warning on implants, and they were so. Unfortunately, most patients don't see. It's not like a prescription that you get and you can get the black box warnings. The surgeons see the black box warnings because we're looking at the implant box when we open it. Patients never really see their implant box, but it was the effort and sort of the desire for the FDA to raise awareness, and so that's, you know, one of their mechanisms for doing so. But one of the very first bullet on the black box warning is that breast implants are not considered lifetime devices, and that
Wow.
they will, depending on lifespan and depending on and a couple of different factors will depend on how long you have the implant. So if I'm doing a breast reconstruction and the patient is 78 years old and I'm placing an implant in, that implant may last, you know, her lifetime. You know, I hope all of my patients have long, healthy lives, but if we're talking about, you know, average lifespan in the US, that implant should last that patient's lifetime. For younger patients, it's definitely needs to be a conversation that the implant will need to be exchanged. It will mean future surgery for you. Now the timeline is hard. What I tell my patients is that the FDA recommends, and this is for a silicone implant, right? For a saline implant, if it ruptures, we'll know it because there's physical changes, and then we go back to the OR shortly afterwards to have that exchange. The
Okay.
real issues with silicone implants, because you can essentially have a silent rupture. So I tell my patients we're going to follow FDA guidelines. The first MRI is 5 years after I put the implant in, and then every 2 years after that. So if we go to 9 years and 11 years and everything is fine, they're happy with the way it looks, then we can just continue. You know, the other thing that I talk with my patients about is we also change with time. So the way I looked when I was 20 is a little bit different than the way I look when I'm almost 50. And so our bodies change, and you place an implant in a 30-year-old, it may look a little bit different when she's 40 or 45, especially if there's been kids and other life events in between. And so
Mhm.
the reason to change that implant might be rupture, or we may be changing it before because we want the implant to match your shape, and things may have changed and we may need to make adjustments. So there's a number of different reasons why we exchange implants. The only one that's sort of really mandatory is a rupture.
Got
Now,
it.
Dr. Light, if I'm thinking about the saline implant, which is what I have, and I do see the rippling, I see it as soon as you held that up. I'm like, oh yeah, that's me, right? So I see that, and I knew that going in. But would I see anything more than that? Because I'm 10 years with my implants now,
Mhm.
right? And I always sort of went on the school of thought, if it's good, don't touch it, right? And but
And
how would I know? It would be definitely, I would know if it ruptured. It would, it's not just
yes.
that rippling.
Yeah, it's not just the rippling. It may take, depending on how large, how much fluid is in the saline implant, and depending on, body size, it may take a few days of absorbing some of that fluid for the volume to go down and for you to notice a difference. For some women, as soon as the integrity of the shell is lost, the breast changes shape almost immediately, and they know something's wrong. For others, it may take a little bit of time, but that will probably be the only change. The only other issue that you might notice long term is the change in the capsule. So if you start to develop a capsular contracture, which can happen in a delayed fashion, a silicone implant that silently sort of ruptures, capsular contracture could be a sign that that implant is ruptured. And so that is sort of the other sort of thing that we're looking at when we have the patient coming in for checkups in between their MRI with a silicone implant.
Yeah. Could you just dive into that, as a breast implant gets encapsulated, can
Mhm.
you just tell our audience what that looks like, feels like? Yeah.
So there's whenever you put a foreign body into the body, there's a reaction to it. So whether it's a breast implant or a pacemaker or really any implantable device, the device goes in and the body creates a capsule of fibrous tissue, almost like scar tissue around it. And it's almost sort of walling it off because it recognizes it as foreign. In 90+% of women, actually, I shouldn't say that. The statistic on the FDA paperwork is about a 15% capsular contracture rate with implants. I think there's a lot of studies that will show it's actually less than that. But what the capsular contracture refers to the capsule becoming thicker, firmer, and tighter. So if you sort of think about what happens there, the capsule around it is just sort of coming down. It's going to make the breast seem a little bit rounder, firmer. It may actually cause the implant to ride up a little bit, and so it's all physical changes. Now, there's different grades of capsular contracture that we use to describe it. It's not until there's 4 grades. So it's not until you get to grade 3 or 4 that we consider it abnormal. Grade 3 means that when you look at the breast, you can see the capsular contracture. It has that high riding, very round, narrow sort of appearance to it. That's a grade 3. A grade 4 capsular contracture is a grade 3 plus there's discomfort. So it's really not until we get to a grade 3 or 4 that we're considering doing something about it. And you can actually, I have patients that have, especially patients with implant reconstructions that had radiation, that didn't want to use a natural tissue option or didn't have a natural tissue option, and they have an implant in. They have a grade 3 capsular contracture. They see it. It's not uncomfortable to them. They don't want to have additional surgery. And so we're just monitoring it. So even though there's a visual change, it's not causing them any distress. And so it's okay to sort of just continue to follow. Once it becomes a grade 4 and it's causing discomfort, on a regular basis, then that's when we would intervene.
And is there anything that the patients can do to prevent that? Is there like I used to hear move right, left, up, down. Is
Yeah.
that something that is
So there's
protocol?
not a lot of there's different things that people will recommend massage. They'll recommend ultrasound. They'll recommend um, different types of physical therapy. there's really no great science behind it, so it's not something that I ever recommend. There is an antihistamine, Singulair, which was at least one paper, if not two, which small subset of patients showed some improvement. So when I have a patient who had a capsular contracture and I'm going back and I'm going to reoperate, which basically means going back, removing the capsule, releasing the capsule. If it's a reconstruction patient and I have the ability to use an acellular dermal matrix, something like Alloderm, that can sometimes help prevent a capsular contracture because you don't form a normal capsule along these biologic meshes. That'll be an option. Or I may, if they ask what are the other options, I'll bring up Singulair. With the footnote that there's not a lot of great evidence to it, but there's not a lot of downside, and we can certainly give it a try.
Okay,
Wow.
thank you.
Yeah, really interesting. We did have a question, and this, I'm not sure, perfectly honest, if this is relative to capsular contracture, but one of our members said their implants keep flipping. She even did a correction surgery and it still flips. It's uncomfortable. Would this be considered a capsular contracture, or is this something else that's going on?
Yeah, it's something else. It's actually almost the exact opposite of a capsular contracture. So the issue that she's experienced is the capsule is probably just a touch too loose. So one of the downsides to smooth implants is that they're smooth, and so they slide and they move. And the inside of a breast capsule is also smooth. Looks very much like the lining on the inside of your mouth. It's sort of, pinkish and very smooth. And so smooth lining, smooth implant, things can get a little slippery. It's actually, I find it most common in side sleepers, because when you're sleeping on your slide, this arm that you're resting on is pushing pressure against that implant all night.
Wow.
And so it's a constant force that will eventually allow the implant. The flipping is not this way because it doesn't make a difference because it's round. The flipping is front to back. And so now you have the back of the implant, which it may be a little bit hard to see, but the implant is a little bit of a dome shape. Now this is a moderate profile implant. Profile meaning it's sort of a medium projection. A high profile implant would stick out more, a low profile implant would stick out less. And so when a low profile implant flips, you may not even notice it because there's just the front and back are not that different. When a high profile implant flips, it's more noticeable because the back of it is very flat and the front of it is definitely has more projection and more shape. And so you'll notice that the front, when it flips, the front of the breast looks a little bit blunted. Now we can flip them back in the office. Flipping it's not dangerous for the implant. It's just, in some patients it can be uncomfortable, in others it changes the shape of the breast. But essentially, where a capsular contracture, the capsule is too tight and uncomfortable. With this, there's just a little bit of laxity that's allowing the implant to move. And so the revision procedures for that usually entail tightening the capsule around the implant to try and give it a tighter fit around the implant. Sometimes if the patient is okay with it, we'll upsize the implant a little bit more. So again, trying to get that tighter fit, and trying to work towards a place where it's less likely to flip again.
Great, thank you.
Interesting.
Yeah. So there's one that says should the implants ever be placed over or under the muscle? I mean, I remember that mine was always under the muscle, right? So did they ever do that over the muscle anymore?
So I haven't, all of my reconstructions now are on top of the muscle.
Oh,
So when I was going through training and when I first went into practice, all of the implants went in underneath the muscle. And this is for reconstruction.
Years.
Yep.
Yeah,
And
years
so
ago. Okay.
it wasn't until probably about 8 years ago that I made the switch to placing it on top of the muscle. And there's advantages and disadvantages, and this is another discussion that I have with my patients. The advantage of putting an implant underneath the muscle, and when it's underneath the muscle, usually it means the muscle is covering the top of the implant and the biologic mesh is covering the bottom, sort of like a sling, right? So the surgeon lifts the muscle up, releases it, puts the implant underneath, sews the biologic mesh on the bottom, so now it's sort of staying in place. The advantage of the muscle is that the muscle is hiding some of that rippling that you see at the top. That's really the only advantage. The disadvantage of the muscle is that releasing the muscle causes more immediate postoperative pain.
Yeah.
There is more chronic pain associated with an implant underneath the muscle because the implant is almost always putting stretch on the muscle, and some patients find it very uncomfortable. And then the third disadvantage is something called implant animation. So every time that muscle contracts, it's pulling the implant up. It can cause sort of indentations and contour abnormalities. Now it's just for a split second while you're using the muscle. When the patient is completely relaxed, you don't see it. But for women who go to the gym and they're in, a workout outfit and they're doing, a rowing machine or any kind of machine that's using the pec muscles, they will see with each motion a constant movement. And so especially for very active women, the implant animation is unsettling. They really don't like it. And so all of those are reasons why I've switched to putting it on top of the muscle, because it avoids all three: acute pain, chronic pain, and implant animation. The disadvantage is that especially in very thin patients, you may be a little bit more likely to see rippling at the top of the breast because the muscle's not there. But that can be treated with fat grafting. And I've transferred many patients from implants underneath the muscle to on top. I've never gone the other way. And so I know, and some of them were actually my patients from earlier in my practice that I put the implant underneath the muscle. They came back years later and they, were complaining about some of these issues, and I gave them the option and they did it. And so those three disadvantages I've learned from experience outweigh rippling. And so most patients are very accepting of the rippling to avoid the other three.
And it's good to know that you can go from one to another. If you do have that history and you want to make the flip to on top of the muscle, that is an option for you.
Correct.
Yeah, I didn't know that. That's interesting, and agree with everything that you said. You're speaking my language right there. Yeah.
I know we have just a few minutes before we wrap. I do want to touch on a few more things, so maybe we can sort of rapid fire. One of which I think, a lot of questions again came in regarding breast implant illness. If you want to touch on that a little bit, Dr. Light.
Yes.
Sure. So breast implant illness, it's patients who have implants in, whether it's for cosmetic reasons, reconstructive reasons, saline, silicone, it runs the full gamut. They begin to experience what's called systemic symptoms, meaning symptoms that affect the entire body. The most common ones are brain fog, muscle pain, joint pain, but it really expands into almost every organ system on the body. It can cause GI problems, pulmonary problems. And so the challenge with breast implant illness is that unlike BIA ALCL, there's no definitive test for it. And so I believe that it exists. I think that it's to say that it doesn't exist when I'm going to use this as sort of a lay term, like an allergy. I don't know that it's really an allergy, but we can have reactions to all different types of foreign substances. I mean, I'm unfortunately allergic to apples because of the protein in the apple skin. So why couldn't someone be allergic to some material that's in a silicone implant? I think that's a reasonable consideration. The challenge becomes when a patient comes to you and they're having symptoms, they've seen specialists, rheumatologists, hematologist, GI specialist, pulmonary specialist, dermatologist, because there's a lot of skin reactions as well that they report. And the workups report nothing, zero, nothing's wrong. They can't find a source for it. And so the patients basically say, okay, I've had all of this started after the implants were placed. I'm very honest with them. It may be the implants. I can't guarantee it. But if you're sort of at the point of, I don't know what else to do, I just don't want my implants anymore, I'm concerned that that's causing the problems, then it's reasonable to move forward with removing them, especially for if it's a reconstructive patient and they have an option of using their own tissue, then that's a natural transition for me to move them into a deep flap or a pat flap or another flap to replace the implant, which is the solution for capsular contracture or many of the other issues that are associated with implants. If it's a cosmetic patient, well, to have the implant was their choice, and to remove the implant is their choice. There's, no one can say that that's not an option for them. Then then it's a wait and see to see if the symptoms get better. And I think a lot of patients report that they get better. Some don't, and so that's part of the honest discussion on the upfront. Is I certainly hope that they get better, but I can't guarantee it. And then the other part of that discussion is, what is the breast going to look like, and what can we do to the breast to try and maintain as ideal of a shape as possible? And sometimes that means doing a breast lift. Sometimes that means trying to replace some of the volume lost from an implant with fat grafting. So there's different sort of reconstructive and cosmetic techniques that we apply to try and restore the breast shape as much as possible.
Wow. Yeah, I had a friend that shared this story with me, had implants put in for augmentation, but really experienced everything that you said. And almost immediately, having them removed, it was like a world of difference. She couldn't believe how much better she felt. It really, really fascinating.
Yeah. So
I'm
I
just
think
glad it's being validated, right? Instead of these women feeling like they're told it's in their head, right? So it's validated, which I'm glad to see.
And I think that if there's a takeaway message from this discussion today is we as surgeons need to be as honest and forthcoming with implants, because if a patient goes into it with eyes wide open and they're truly educated and informed, then they're not going to feel like they were bamboozled a bit, or not completely informed and something was hidden, because that leads to a feeling of resentment and just not a place that we want any patient to be. And so to combat that, the FDA and the FDA does, they're great at some things, not great at other things, but I do think that their efforts with breast implants have been commendable. They came out with something called a patient decision checklist, which is essentially a consent form that reviews a lot of breast implant illness, BIA, ALCL, capsular contracture, all of the issues with implants that we now have, or plastic surgeons should have their patients sign prior to getting an implant. And so it's a way to sort of ensure that, okay, we've discussed all of these points, make sure that they were part of the conversation so that the education is better and we don't have patients feeling like the medical community is not doing right by them.
Yeah, thank you. I know in that same category of just illness, we just had one of our participants said that she's just been getting recurring infections, trying to get her implant it was removed, and then trying to go back and get the spacer, and then another infection occurred. Is this normal, or is this like her body rejecting it, but the other one's working? So that's where the doctor's having a little bit of trouble.
Yeah, I mean, I think that I don't think it's rejection. I mean, I think that you can, sometimes it matters how much time you wait in between removing an implant for infection and putting it back in. I usually wait a minimum of 3 months, just to allow the body to sort of adequately clear the space
That's what
and
she did
truly treat
do.
the
It was 3
infection.
months.
shooting
Mhm.
at 2 months. Yeah.
Yep.
So, you know, I think that it's, despite best efforts and despite, you know, doing everything, you know, in an appropriate way, treating appropriately with antibiotics, you know, sometimes implants, because it's a foreign body, we run into issues with it, and you may need to step back for it and look for another option, or may just need to give your body a you know, a little bit more time to recover before trying to move forward again. In my experience, once you start to have an issue with an implant infection, it's it's often not salvageable. I know a lot of surgeons will have their patients in the hospital for a week or two on IV antibiotics. Um, I think that it's better to get it out, get the infection cleared, because even if you keep the implant in and you salvage it, there's a few things that increase your rate of capsular contracture: bleeding around the implant, infection, radiation. So even if you got away with not losing the implant, the chances of you having a capsular contracture now are much higher, and that's not the result that you want either. So sometimes removing the foreign body, heal from the infection completely, and then get back to completing the reconstruction is the best course.
Got it.
Thank you.
Okay.
All
Yeah.
right, one more,
Okay.
Erin, right?
One more, and then
We
we'll
have
let you
more,
get
but
on
we're
with your
only going
day,
to do
like
one
your
more.
life. I know. So just a general question that we came from varying angles about restrictions on range of motion or lifting, riding roller coasters, you know, grandkids that run into them, you know, what, any words of advice regarding sort of the lifestyle things that we might enjoy, playing, moving, regarding, you know, after having implants placed?
So initially, I definitely restrict my patients from part of it is because of discomfort. So especially for reconstruction. So with a augmentation, you'll recover faster and you'll get back into the groove of things a little bit faster, because it's not as much of it, not as involved of a surgery. So for reconstruction, especially a prepectoral reconstruction, the implant is placed. There's a biologic mesh now supporting it, because there's no muscle at the top, so the mesh is at both the top and the bottom, and we want that to heal so that there's strength to it, because that biologic mesh is going to support the implant, offload the tension from the skin, and make sure that the cosmetic result is as long lasting as possible. So I usually walking is totally fine, but usually avoid a lot of bouncing activities, upper extremity like running, upper extremity activities for about 3 or 4 weeks afterwards. The biology of wound healing is that you have maximal strength usually somewhere between 6 and 8 weeks. So I want them to be pretty close to that before they really start stressing that. Now, once that point passes and you're 2 months post-op, I really don't put any restrictions. So if you enjoy roller coasters, ride roller coasters. You definitely don't have to, I mean, you don't have to be concerned about the average grandchild running into you. I have patients who have had breast reconstructions and they're boxers, and they're
Wow.
you know, martial artists and play contact sports, and so you know, I think that their implants are pretty resilient. I've other than a motor vehicle accident, have never had someone come back in with an implant ruptured for, you know, any kind of activity that enjoyed. So I let my patients return to whatever things they enjoy.
I love that. And that's really reassuring, I'm sure, just to know that they can do the things that they love and bring them joy in the long term. You know, I love
Yep,
that.
Yeah,
100%.
a good way for us to end the segment.
Yes, on the
know.
positive note.
I
Thank
love
you,
that.
Dr.
Do
Light.
what you love.
Yeah,
Yeah.
always a pleasure to have you on. We really appreciate you. Your expertise is valuable, and our community listens. So I feel like any that we didn't get to, Erin, maybe they can actually email us at info@uniteforher.org, and we'll answer those questions for you and get them back to you. So that way,
Yeah.
in case we miss something, we can ask Dr. Light to answer that question
Yeah.
for us.
Absolutely, I'd be happy to.
Great,
Thank
great.
you.
So that's info@uniteforher.org. Great.
Great.
Thanks so much.
Thank you.
Thank you,
Have a
Dr.
wonderful
Light, once
afternoon.
again.
Thank you.
My pleasure. Take care. Bye-bye.
All
What
right,
a great
Erin.
segment. So good.
I learned a
So
lot.
good.
Again.
So did I.
know, because Erin, I am past that 9 years. And I'm like, what do you mean? Wait a minute. They put them on top now? I'm not hearing that, right? That conversation the way I was
Yeah.
before.
Yeah. So it's good to have some perspective, especially, that long term, and
Yeah.
even just to start to inquire if some of that is specific to a certain situation, or just to have that conversation with a person's surgeon. It's just
Yeah.
important.
I just love that we continue to progress and they continue to get better and better and look better and feel better. And that's good progress because our community deserves it, right? And
Yeah,
very good progress. So thank
absolutely.
you, Erin. Yeah, we have a couple more reminders. I'm going to do this one because I love saying dear dietitians, because our dietitians are dear. That's why I like saying that. Every Friday, streaming live on Unite for Her's Instagram at 10 o'clock. We're going to have Catherine joining this Friday. They rotate our dietitian team, and I just love this section. So really, really good that you can get in there and get all of your top of mind questions answered and join us live at Dear Dietitian. And then we have a virtual hangout, April 2nd, 5 p.m. Eastern Time. We'll be joined by Sissy Silva from Cancers and Careers, and she's going to be helping us with balancing work and cancer. And this has not been the first time that we had Cancer and Careers on. So another way that you could really go through our library, look at some of the topics. So valuable. Love this organization. We know that working after cancer is challenging. It's challenging. And this segment will focus on those complexities of navigating work during and after treatment. So please join us on April 2nd at 5 p.m. Everything is on our library, as we all know. Our community, we call it, Unite for Her Connect. Hopefully you've noticed our new logo, our new community, because we feel it. We feel you always with us every single episode that we have. We enjoy seeing you over and over again, and glad that we can bring you the most top of mind subjects right there front and center for you to get info from the experts.
Perfect. And then,
that's a wrap.
yeah.
Right?
Yeah, wonderful. Thanks again to our sponsors for supporting our entire education initiative, West, Merck, and Daiichi Sankyo, with additional support from Gilead Sciences, Lilly, GSK, Pfizer, and Agendia. And be sure to join us for all of those future education segments we have coming to you each month.
Yeah. All right, everybody. Have a wonderful rest of your week. Thank you for joining us.
Thanks, everyone.